So, y'all, thank you for the testimony today. Exceptionally important to be able to get out there. All of us deal with this. We all have casework staff that try to help chase through things. So we hear it as well. This is really important that this gets out, and we find ways that are practical, realistic ways to be able to actually process this. Dr. Resnick, I want to try to drill down a little bit from the physician side of this. So insurance plan reaches out, let's say early summer, and says we're looking to be able to put all of our networks together for next year. You want to be in network or out of network? They negotiate you. They tell you this is what we're going to pay you flat out. And no, we won't negotiate with you. And you go through all that back and forth on it, finally resolve it. By the end of the summer, they put out their open season plan with their list of all their providers on it. For the next year, people select their plan based on who their providers are, if it's near them or their own physician is there, and then they pick up the phone and start calling people. Is there a requirement for physicians if they say I'm going to be in a plan to actually be in that plan for the next year? Or can a physician say, yeah, I'll be in the plan, and then let's say January, February, March decide, nah, I really don't feel like being in this plan? Are they locked in typically? And again, company to company may be differently, but is there a commitment on the physician side? If I said I'm going to be in this plan for a year, I'm actually going to be in the year.
In general, physicians contract on an annual basis, but I think this probably varies by state and by type of plan. And we see plans terminate people mid-year for no reason.
Right.
So there's the other piece of that as well. But we'll get back to you with more information.
That's right. That's helpful, because that's one of the areas that we've got to be able to resolve is there a commitment from the physician also be in the plan? We've heard several times from different plans that will say, or from individuals that will say, by the time that I actually pursued the plan and got into the plan and started in January, February, started calling people, they said, oh no, I actually dropped out last year, but they're still listed, or I just changed and shifted over. And we're trying to figure out the mechanics of where are all the players in that.
And if you talk to that physician, they probably called the plan just like your office staff helping people in your district and your state have, and probably sat on hold for 3 hours and then got disconnected trying to update the directory themselves. So the plans have made it really difficult for the docs.
Yeah, really difficult for the patient and for the docs on it. And that's what's been the challenge on this. So the next layer on this, Dr. Ryder, let me ask you about this as well. From the industry side, and you're dealing with this, there's a lot of insurance companies right now that aren't following the current CMS regulations even. So the issue always comes back to us. They're not following currently. Let's add one more and see if they'll follow that one as well. What do you see as the solution here in this process? Because I don't want a single constituent to be able to call and say, I don't know who that is. Ms. Myrick's testimony was powerful to be able to say, don't know who that is. That person died. Sorry, we don't take people anymore. We haven't been on that for years. That's plans just not updating and doing their work, but they're already violating CMS rules. So from an industry perspective, what's the answer on this?
Standardization. Across the board, and that's a challenge because most plans are regulated on a state basis, and states have their own variations on what they do or don't want. But I think it starts with very, very detailed aligned standards. You know, and the old adage is standards are great because there's so many of them, and that's the problem. We're now dealing with, you know, Medicaid standards, CMS standards for Medicare, Medicare Advantage, state standards. So it's
yeah, there are state regulations, but this is a Medicare Advantage. This is a unique. This falls right into this committee of what's happening in Medicare, Medicare Advantage, and such. So to create that centralized standard for that. Dr. Resnick, were you want to say something?
Well, your colleague earlier mentioned carrots and sticks and liking carrots, and I completely agree. Transparency would be great. Carrots are very helpful. My fear is I'm going to be walking around with a backpack of carrots for another 10 years, and they're going to rot in my backpack because I won't have any to give out. The plans are so consolidated and have such an incentive to look like they have a full network when they don't. That I think in the Medicare Advantage space that you have jurisdiction over, and in the exchange space that you have jurisdiction over, we do need some sticks. We do need monetary fines. These are big plans with big resources that have the capability and responsibility to put out accurate direction.
So the sense would be, like the chairman was saying before, if we end up calling a secret shopper type calls or whatever process that we do from a third party or whether it be a federal entity and find out, no, these folks don't actually exist, then they get a fine to be able to come in. So it puts a requirement on them to be able to fulfill that.
Right. There's always going to be a little background noise and a few inaccuracies, but when 80% of the directory is inaccurate, I think you can say that is a planned failure.
That's a massive issue, and it's a big issue for us in rural Oklahoma, that there will be companies that will put out a plan and that everyone looks at it, selects a plan, then they get into that plan in January and find out it's not real. And they can't go anywhere. Or if they're going to go anywhere, they're going to have to drive 150 miles to be able to get to someone. They assume the people that were listed locally actually existed and accepted the process. So Appreciate your testimony today.
And